A panel discussion at the NCQA Health Innovation Summit on November 1st in Nashville offered 9 useful insights into why and how to build data interoperability as the bedrock of better healthcare. Panelists made this technical topic seem both urgent and relatable. These 9 takeaways are instructive even to people who don't work in health IT. Acronyms such as HIEs, FHIR, and TEFCA came up. If you need background on those, check out Quality Matters episodes 7 and 8. We'll link to those episodes in the show notes. I'm Andy Reynolds. Let's listen to the highlights of the Nashville conversation. Arcadia Chief Strategy Officer Aneesh Chopra served as panel moderator.
Here we go. We're going to have a lot of fun this session. We're going to go deeper on the role of interoperability in pursuit of better patient care.
Aneesh started the conversation by inviting Dr. Marc Overhage, Chief Health Information Officer at Elevance Health, to discuss what's at stake and what stands in the way of data interoperability. Marc mentions CCDA files. That stands for Consolidated Clinical Document Architecture, the most widely used format for health information exchange.
So I'm going to start with my friend Marc. Marc had been part of the early OGs in data sharing. The Indiana Health Information Exchange program was one of the first to pool the data and make it useful in the community. Marc, why don't you just share a little bit about what we need to do to get data to its highest and best use?
Bringing data together for a particular patient so we have a comprehensive view for clinical care, quality assessment, predictive modeling, whatever it might be, is still the golden ring that I'm trying to get to. We have standards, and that's great, and those continue to improve. What has been slower than I would like has been the careful adoption of those. My colleagues talk about semantic interoperability, making sure you've got all these nuances right. So, for example, have handoffs of data, a mammogram was performed. That may show up in a CCDA, properly structured, properly coded, wonderful, but now I'm going to use it somewhere else. Is there a report? Is there a result from this mammogram? Maybe I don't even care what it is. I just want to know that it was actually done. Semantic is one of those weird words that informaticians use, but understand it the way it needs to be understood is the heart of the problem. It's pretty amazing, the volume of data and the number of people that we're able to access and share data between payers, providers, other participants in the healthcare ecosystem. But we've still got a ways to go in fixing the nits at the edge, is how I think about it.
Based on the broad understanding that Aneesh and Marc articulated, let's take a look at our 9 lessons or our 9 takeaways now. Lesson number 1. The basis of interoperability is trust. In fact, trust is the first word of the relevant interoperability regulations in TEFCA, or the Trusted Exchange Framework and Common Agreement. Laura McCrary, CEO of KONZA, references the Office of the National Coordinator, the ONC, and the Recognized Coordinating Entity, RCE. The RCE implements TEFCA.
For many years, people have asked me, what's the most important thing in health information exchange? The answer is trust. Providers must trust payers, right? Payers must trust providers. There must be reciprocity and alignment of incentives. Providers are going to get something. Payers are going to get something. And together, when you align the incentive, you're going to have a win. So TEFCA has the promise to solve a lot of the problems we have today in quality calculations, getting complete data for purposes of HIEs, getting data for risk adjustment, getting data for closing care gaps. TEFCA has the promise of that, but it requires at its core trust. And for the last year, Mickey Tripathi and the ONC and the RCE have been building a trusted governance framework that allows organizations, providers, and payers to trust each other.
Quality Matters listeners may recall we talked about TEFCA in episode 7, and we met Laura McCrary in episode 8. We'll link to those episodes in the show notes. Let's move on. Here's lesson number 2. To remember the relationship between health information exchanges, or HIEs, and a qualified health information network, or QHIN, think about highways. Here's Laura McCrary again.
There'll be a lot of QHINs. You'll have a lot of choices about which QHIN you want to participate in. This is the way I explain this to my mom. She still doesn't know what I do, but this is the way I explain to my mom. A QHIN is a superhighway. Like in Kansas, it's I-70 that goes all the way across the state to the Rocky Mountains. HIEs are the on-ramps and the off-ramps of the superhighway. And some EHRs will be in the on-ramps and off-ramps.
Lesson number 3. QHINs were created to work around a geographic limitation of health information exchanges, or HIEs.
The states received money to build their own health information exchange. There were good things about that and bad things. One thing that was bad is there's a road that runs between Kansas and Missouri. It's called State Line. Imagine that. People cross that state line every day, and they have no idea their medical records are not going to cross with them because these HIEs were geographic based. Their insurance may not cross with them. We were trying desperately to resolve that problem.
Lesson number 4. QHIN's challenge isn't providing enough clinical information to practitioners. The challenge is providing information in a way that practitioners can use.
I'm in this business for 20 years, and there's no excuse that we are still where we are in terms of interoperability and you not being able to get medical records on your patients in a way you can use. I had a doctor from Salina, Kansas. He called me and he said, Laura, I just got 272 documents for one patient. What would you like for me to do with these 272 documents? I've got to provide care to this patient in 5 minutes. So what would you like? And you know, it's a fair question, right? We've created the ability to transport the documents, but we can't deliver 272 documents to a doctor and expect for him to provide good care. It's not enough for the HIEs or QHINs to say, we're going to go get the data and deliver it to you. We've got to deliver you something that is meaningful and helpful.
Lesson number 5. To understand how data flows through the system and where data exchange can go wrong, focus on the second and third steps of a 3-step process. Here's Aneesh Chopra and Marc Overhage again.
Can you share a bit about the life of a data element? What does it take to calculate a quality measure? And how did it get converted and transformed and passed around into the submission for reimbursement? Can you walk us through that journey?
That journey has at least 3 big phases. One is the phase inside of the health system, bringing that data into a data warehouse and standardizing at that level. That's sort of the first chunk. The middle is, in some ways, the most daunting. And by the middle, I mean moving it from the health system to, say, a payer. There's the standards question. Is it a flat file? Please don't. A CCDA or a FHIR or something else. But also the pathway that it takes. Many health systems have lots of partners, and building direct connections is hard. Transformations are necessary to align information through aggregators, or through EHR vendors as aggregators, or through national networks where there's fewer hands touching it. Frankly, we have less problems in the middle, and it's in the transformations from the first to the second or the second to the third, which is the recipient, like a health plan, where receiving data from thousands of different providers, from immunization registries, from other sources. When we think about interoperability, we often think about that middle piece of things to a health system like claims data, but it's really at the edges. It's at those interfaces, which is always the problem, and any computer scientist will tell you where the problems are. It's the interfaces.
Lesson number 6. Sometimes getting what you want out of data exchange is more of a job for lawyers than it is a job for IT personnel.
Laura, I want to know whether the payers can be a part of the network. Do you have any final words about how and in what manner we get them involved now?
Sometimes it's not technology that is the problem. Sometimes problems have to be solved contractually. For the payers, there is an easy solution to how you can get data for healthcare operations and for payment off of TEFCA. You simply include in your contracts with providers that they will respond to all TEFCA queries. That doesn't mean just treatment. It means treatment, payment, healthcare operations, it means benefits determination, it means public health. This problem could be solved contractually, and in your negotiations with your providers, you align the incentives appropriately. It's not a technology problem. It's a problem of not having incentives aligned. Providers, if you sit down with your payers to sign your contract, the payers want to get this data digitally. Don't you want, as providers, to provide it to them? Aren't you tired of that nurse coming out to your office and making copies of your EHR and then copying it on your copy machine? I mean, that is ridiculous. So if you sit down with the payers when you renegotiate your contract and say, I'm going to use the QHIN, I'm going to respond to queries on the QHIN for payment and healthcare operations, and I expect you, payer, to accept my data for purposes of our quality reporting, and I don't want anybody coming out to my office to make copies on my copy machine any longer. This is not a technology problem.
Amen.
Lesson number 7. The industry faces a big binary choice about how to organize quality information. Here's Aneesh Chopra and Marc Overhage again.
There's a debate. Is the EHR the center of the healthcare universe, or is there an opportunity to think about other ways health systems and health plans can collaborate in service of better quality? There's really 2 technical architectures envisioned for quality. One is put everything in and out of a single EHR, and then have it run measures, and then have it report out the results. And the other acknowledges fragmentation. I get care here, I get care there, I may need a digital service over here, but an accountable entity can coordinate my care outside of an individual EHR. While that may seem silly to think about as a debate, it has a huge architectural difference in how we regulate. CMS is mandating the use of the QRDA aggregation framework, which is the EHR-centric model, for 500 ACOs. This is still $1 million a year tax on every ACO. And now we're talking about digital quality measures that can do quite the opposite. In fact, we're testing them. Marc, does it matter that we have to decide this?
No, I think it absolutely matters. To your point about fragmentation from a population health perspective, we have to think about it more as it needs to live outside of the EHR. It may need to live inside the EHR to a degree as well. But I think depending on your perspective and the population that you're thinking about, that sort of cloud-based or Uber coordination mechanism is key.
Lesson number 8. Bulk FHIR and cloud computing are a powerful combination that's even bigger than the other things our panel talked about. Here's Aneesh Chopra and Abdul Shaikh, Global Leader for Population Health at Amazon Web Services. Aneesh starts by mentioning the BCDA. That's the Beneficiary Claims Data API that accountable care organizations use to retrieve Medicare data for their beneficiaries.
I do want to get to Abdul. So a big part of the power of Bulk FHIR is the ability to kind of predetermine a group so you can have a trusted relationship. The BCDA, the CMS FHIR server, everyone hits that every morning at 7 a.m. Anything new on my population since yesterday? And in about 35 seconds, the answer gets done and you move on to the next. It's a one-to-one hit. Do we need to be more tight in how it's done? Help me have Bulk FHIR might play a role in that.
The cloud can scale, right? There's approaches like serverless computing where you're only paying for your use of the cloud when you're actually using it. So the cloud allows you to scale as needed depending on the computational needs or the data sharing requirements. One of the things I'm excited about is this notion of stateless computing, right? Which is where you can actually leave the data within separate organizations and then anonymizing the data, having an MPI, using privacy-preserving record linkage, bring the compute to the data. And what that allows is to drive value across different data stewards. That's maybe a little forward thinking when we look at the QHINs and what TEFCA can do, but the cloud allows you to scale because the technology is beyond the actual use cases right now.
Lesson number 9, an appeal from Aneesh Chopra to join the Bulk FHIR Quality Coalition.
All right, let's end on a high note. So we're over time. Here's my advice. Sign up for the NCQA Bulk FHIR Quality Coalition. We are advertisement, the Bulk FHIR Quality Coalition. We are very open to all participants to be a part of the NCQA initiative to test whether the new modern rails can be used to calculate at least 3 quality measures. And so come in, the water is warm.
And there you have it. 9 lessons or insights into interoperability. They are, number 1, data exchange is all about trust. Number 2, QHINs are the superhighways of health data exchange. HIEs are the on-ramps and the off-ramps. Number 3, QHINs were created to work around geographic limitations of HIEs. Number 4, QHIN's challenge is providing information in a way that practitioners can use. Number 5, to understand where data exchange can go wrong, focus on the interfaces between steps. Number 6, data exchange agreements often require legal expertise as much as technical expertise. Number 7, the industry faces a big binary choice about how to organize quality information. Number 8, bulk FHIR and cloud computing are a powerful combination. Number 9, join the Bulk FHIR Quality Coalition. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.